Good morning. Yes, well, thank you for inviting me to come and talk from a human perspective about clinical excellence and overtreatment. Clearly, there's some overlaps with Polly's views, but the way we treat humans is very different to the way we treat animals, particularly in this country. So I somewhat feel a bit of a fish out of water in this veterinary audience, but I hope you'll forgive me talking a little bit about human medicine this morning. So I work at the Royal Marsden Hospital, which is a centre of cancer treatment here in London, and we specialise in trying to cure cancer and do lots of research on patients who have cancer. So my specialty, palliative medicine, well, what is it? So I look after patients who have a life-threatening illness. Doesn't need to be life-limiting, definitely, but a life-threatening illness, and we treat them holistically and their families and try and approach them to improve their quality of life, whether that be physical, psychological, practical needs, anything they may have whilst they have a life-threatening illness. So we see them at any stage of their illness. So particularly at the Marsden, we see them at diagnosis through to the end of their life and come and go as and when we are required to try and help treat symptoms and be available to support them. How do we work with other doctors? Well, that is the challenge sometimes, because the colleagues that I work with, somewhat in the echoes what Polly just said at the end of her talk, see death as quite a failure. So they are here to focus on providing cures and treatments and sort of somewhat sideline the quality of life aspects that we so care dearly about for these patients. We work alongside the patients and our colleagues to think about what are the expectations of the treatment they're having and plan for their future. And sometimes that means that there is a change in direction of their care, and different goal setting depends on what matters to the patient and somewhat what matters to the clinician. So there are choices that befall our patients at the Marsden as to what they may want to have going forward in the future. This is where I'm going to talk a little bit about experimental treatment in humans. So we run a phase 1 service. We look after patients who are having phase 1 clinical trials in Sutton, where I particularly work at the Marsden. And as you can see there, phase 1 clinical trials are really there just to look at the safety and adverse events from a new experimental treatment. The human subjects that go on to these phase 1 trials at our institution are reasonably fit, but have no real options left for standard of care treatment. So they are hopeful and wish for benefit from experimental treatment. However, they're pretty desperate often and will take on treatments whether or not it's actually going to benefit them going forward in the future. You probably, as Polly talked about, the Declaration of Helsinki kind of governs experimental treatment that we provide to human participants and human subjects in the world. So this is a picture of their meeting, I think, in Helsinki in 1964 to develop this declaration, which came out of the Nuremberg trials and the Nuremberg Code, which looked at appropriate and safe use of participants in research studies. So the World Medical Association, now known as the World Health Organization, made these recommendations to guide doctors in biomedical research involving human participants. So really what they're saying is what we know now as we continue to practice, is that the research that we do on humans should come from results from laboratory-based experiments and animal experiments. This is in humans. They should be reviewed by an independent committee prior to initiation. So all research trials in the UK have to go to a clinical research committee who will decide whether it's appropriate for human participants to take part in that trial. And that's to be a pretty scrutineering process and takes into account views of lay members of the public, plus informed professionals, plus lots of patient and participation of patients who may have that condition or have family members who have that condition. The crucial thing is informed consent. So we're privileged in human medicine to be able to ask our patients, would they like to take part in this trial? And that's important in terms of trying to ascertain that they with free will, enter into a trial with some understanding of the risks, benefits and burdens that will befall them in the trial. I'll talk to you a little bit more about informed consent because I have a little bit of concern about really, is it truly informed consent for patients who are desperate for having further treatment? The other crucial thing is that research should be conducted medically and scientifically and by qualified individuals. So you can't come off the street, set up a clinical trial and involve human participants. You have to be GCP trained, we called it, so have good clinical practice training and understand the kind of scientific basis of what you're doing. The crucial thing really is that the risks should not exceed the benefits. This is always challenging in experimental medicine, particularly in phase 1 trials, because you know that the purpose of you doing the trial is to explore the safety and adverse events of that treatment. So you probably know that you're probably not going to provide huge amounts of benefits to this patient, but as long as the trial protocol is kind of explained and thought about and talked with the participant, then they're allowed to take part in the trial. Informed consent I've put here, or is it? Challenge, I think. We expect patients to sign informed consent about entering into experimental treatment. We are told, we explain to them that it's of their free will, they're allowed to withdraw at any time and their ongoing treatment will not be affected. But most of the patients I see who are entering into clinical trials towards the end of life are offered the option of a clinical trial, which may or may not provide benefit, versus what we call best supportive care, which is a euphemism for palliative care, which means no standard of care, chemotherapy, radiotherapy or surgery is available, but there may be some experimental treatments that may benefit them going forward. And I think there's two things that worry me a little bit about early phase clinical trials and consent process. I think there's this term therapeutic misconception, so a misunderstanding of the purpose of the research, and a therapeutic misunderstanding of the benefit that they may receive from that research. And I think my colleagues who undertake these trials are aware of those challenges, but I think the patients that I see who've entered into a clinical trial definitely feel that at all costs they wish to try and prolong their life by entering into a clinical trial, whether or not it really will benefit them in the long term. The challenge I also have with some of the clinical trials we put patients on is it prohibits them having some other treatments that may improve their quality of life, such as some other medications are not allowed on the clinical trial, or they can't have radiotherapy for bone pain whilst they're on the clinical trial, or steroids for bone pain whilst they're on the clinical trial. So some of that can be a challenge to kind of work through with these patients. But they are allowed to make that choice, and I suppose the difference between human medicine and animal medicine is that they are allowed to take part and withdraw at any time, and it's their decision. So outside of experimental medicine, what do we provide for patients who require end-of-life care or stages of palliative care throughout their diagnosis and illness? So you probably know this already, but I thought I'd just give you an idea of the layers of care we provide. So we see patients at any stage who have a life-threatening illness for symptom management, improving their quality of life. That can and does include ongoing treatments with palliative chemotherapy and radiotherapy. Sometimes palliative surgery takes place if that's the only thing that will provide clinical benefit to the patient. Improving community support. Psychological support is very important, and practical social needs that they may require regarding housing or their family and things. The next stage really is the kind of entirety of end-of-life care. So that's when you think probably patients are in the last weeks and months of life, and then you might think about what symptoms will benefit the patient at that time, what other things should we be considering in terms of home support, psychological and spiritual care, and really at that point trying to sort of drill down what medical treatments are providing benefit to the patient. And then terminal or very end-of-life care is when we think people are in the last days to hours of life, and we're really focusing on really drilling down on those specific symptoms that they might experience at the end of life and maximising support to the family and providing spiritual care. So this can be done in any setting, is patient and family focused. The aim is trying to achieve the patient's goals, whatever they may be, whether that be living to get married or see a grandchild be born or to go to Wembley Stadium or some sort of experience they want to achieve, trying to improve symptom control, supporting the physical, emotional and practical needs, and focusing on what can be done rather than what can't be done at that time. I suppose I just wanted to sum up by saying There are challenges and benefits in working with patients who are towards the end of life who may be having experimental treatment. But I'm trying to say today that I hope that there's a twin-track approach. We very much believe in the fact that we can work alongside ongoing treatments, whether they be experimental or proven benefit to the patient. But we want to be there for planning for the worst. So we hope that they will benefit from these treatments, but if not, what would happen next? My concern lies in the fact that sometimes over-hope and over-expectation can limit realistic conversations and not allow some of these plans to come to the fore or goals to be met. The kind of ethical debate lies in whether this is the best use of time for the patient. Often clinical trials towards the end of the life require frequent blood tests, frequent admission to hospital, at least once or twice a week for most of the patients on clinical trials, require quite a lot of blood samples and clinical record forms and lots of investigations to be completed. Is that the best use of time when time is limited for patients? And then some patients say to me that they're fully aware that they may not benefit from the treatment they're having, but they have some altruism for ongoing treatments for the future. And that provides this sort of hope and benefit to them as a driver in their life in terms of ongoing future and providing benefit for other patients. So that is the end of my talk. It's probably a bit short, but I think we'll have some discussion.